Welcome to the NWAETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. David Spock to introduce our guest.
We're going to go ahead and kick it right off today with our lecture. We're very fortunate today to have Savitha Subramanian, who is going to give us a talk on dyslipidemia management in HIV positive individuals. Savitha has a special interest both clinically and in research in lipid disorders and is an assistant professor here at the University of Washington in the Division of Metabolism, Endocrinology, and Nutrition. I'll go ahead and turn it over to her.
Hi, thank you for having me. And so we'll get started. So I've been given the task of talking about 100-page guidelines in 15 minutes. But no, I've kind of abbreviated it so that we can put it in perspective in terms of treating HIV-positive individuals. So I have two objectives which we'll go over. The first part of the talk will talk about the new guidelines, review the American College of Cardiology, American Heart Association blood cholesterol treatment guidelines that came out in November 2013, and how we can apply it in the clinical setting, the positives and negatives of those new guidelines. Will be the first part of the talk, and then we'll move on to discussing cardiovascular risk and management of dyslipidemia in HIV-infected individuals. And I have a couple of cases that I got from Dr. Wood for discussing the various lipid issues, and there are also two other cases which I'm sure we'll discuss. So let's talk about the guidelines. So far, everybody's been familiar with the ATP3 guidelines, which have been in use, well used, utilized in the last 11 years, since 2002, January, when it came out, and then revised in 2004, where they had specific LDL targets under 100 or under 70, depending upon the risk. But these new guidelines were actually supposed to come out as ATP4. However, the people who put these guidelines together couldn't come to a consensus. The NIH finally threw in the towel and said, okay, American Heart Association, ACC, you guys take this over. And then they just went with it and put it out in 3 months' time, from July to November 2013. It was done and finished, and that's how this all came about. So the key points, key features in these guidelines is that there are really no specific LDL targets or numbers as such, what you shoot for when you're treating a patient. The guidelines identify four groups of patients who benefit from statin therapy. And another interesting part of these guidelines is that there's a risk calculator or a pooled cohort equation that has been developed to estimate the 10-year atherosclerotic cardiovascular disease risk. And also these guidelines have outlined safety consideration in patients who are being treated with statins very nicely and in quite detail. So who are the four groups of patients or individuals who benefit from statin therapy? So there's the secondary prevention folks, so the people who already have known cardiovascular disease. And the important thing here is that this clinically evident ASCVD includes stroke also. This was not part of the ATP3. So the ASCVD is essentially patients with cardiovascular disease of any sort, MI, stroke, angina, peripheral vascular disease of atherosclerotic origin, TIAs, etc. The second group of individuals are the people who have very high LDLs. They picked an arbitrary number greater than equal to 190. That's not really evidence-based. They had to pick a number. They picked 190. So is 190 better than 180? Really, we don't know. But for all practical purposes, we'll use 190 as the very high LDL level. Then the third group of individuals are those with type 1 and type 2 diabetes, age between 40 and 75, and those with an LDL greater than equal to 70, which is essentially everybody. So all diabetics in that age group. And the fourth group of individuals are those who have an LDL of greater than 70, and when their risks are plugged into the calculator, they have an ASCVD risk that the calculator spits out as greater than equal to 7.5%. So that's where all the big hoopla has come up with the use of the calculator and identifying risk in these non-diabetic middle-aged individuals. So how do you treat these individuals? There's two intensity statin therapies that have been advised or in the guidelines. So one is the high intensity statin therapy, and they just define this as a dose of statin which decreases the LDL cholesterol by greater than 50% on an average. And the drugs that they recommend for bringing this kind they recommend using atorvastatin and rosuvastatin for this intensity of statin therapy, the high intensity. So high doses of atorva and rosuva, 40 to 80 and 20 to 40 of the rosuva. The other intensity statin therapy is called moderate intensity statin therapy, and this is defined as a daily dose that lowers LDL cholesterol by about 30 to 50% on an average. And the doses here, as you can see on the screen, are atorva 10 to 20, rosuva 5 to 10. You've got Simva, Prava, Lova, all the other statins. And I want to also point out pitavastatin, which is a lower dose statin, which can be used particularly in the context of HIV, which we'll talk about towards the second half of the talk. So pitava 2 to 4 milligrams. So how do you use these medications? So here's a diagram. Once you've identified the risk, so this is all comers. This is let's say these are HIV non-infected individuals. You have an individual who doesn't have heart failure or renal disease. You screen them for cardiovascular risk factors, so essentially smoking, hypertension, diabetes, and measure their lipids. And this is a blood cholesterol guideline I want to point out. So they say measure the LDL cholesterol, which is a calculated number and not an actual measurement. So if you look at the two arms on either side of the slide, so it's pretty straightforward. You have somebody to my left, I guess it would be your left also, known clinical CVD. So these are patients who need secondary prevention. So you put them on high intensity statin therapy, and this is something we already do. And on the right side, you have the genetic individuals. Typically, when you have such a high LDL cholesterol greater than 190, it's most likely genetic. It's not defined as genetic hypercholesterolemia in the guidelines, but it's implied. And those are the individuals who have very high risk of coronary disease, stroke, et cetera, and so they require high intensity statin therapy. In the middle two arms, you see the ones with the diabetes. And there, all diabetics need statin, but the way the guidelines define it or describe that you should do this is you plug the diabetes, the individual with diabetes, their parameters in the risk calculator, and then you look at the risk that the calculator spits out. If the risk is greater than 7.5, you give them high intensity therapy, and then if it's a lower risk than 7.5, then you give them moderate intensity statin therapy. Now the other prong there, the individuals with no diabetes, essentially this would include all middle-aged individuals where primary prevention is important to do. And these are individuals with LDL greater than 70, which is essentially everybody. I don't know anybody who has LDLs of 50 unless you're, vegetarian or with very low fat intake or something like that. So essentially everybody between the age of 40 and 75, you plug them into the risk calculator and look at their risk. And if it's greater than 7.5, you use moderate to high intensity statin therapy. So this is where they're kind of iffy. And this is where the big problem arises, and which we'll talk about in the next slide. These guidelines are a big shift in thinking compared to the ATP3 guidelines, where you had a certain number you were shooting for, and that's where all the hoopla has arisen, because people are not, this is a big shift in thinking. And especially in the community, providers need some more guidance, and that's actually lacking in these guidelines. But there's positives and there's negatives to anything. I think a positive is that, it eliminates an actual number you shoot for. It eliminates actual LDL cholesterol goals. And in our lipid clinic, I actually don't shoot for exact numbers. So is 100 better than 101 or 102 in an LDL? So there's that part. So there's no number you're shooting for. They've included stroke as an ASCVD risk, which didn't exist before. And then the risk calculator is actually most likely appropriate for middle-aged individuals, and by middle-aged I am going to loosely say individuals between 40 and 65, because those are the individuals where you need primary prevention, and the higher the LDL cholesterol, it's a cumulative risk for cardiovascular disease. So when you get them early, it's probably good. And then the guidelines also are quite well written, and it details the safety guidelines when you're using statins, what to do when somebody has side effects on statins, and there's a very detailed table. So those are the positives. The controversies arise because, again, some providers don't like the fact that there's no actual numbers that have been suggested for the LDL cholesterol. But beyond that, the big thing is this risk calculator that's been created. You plug in the numbers, and the numbers usually are age, sex, HDL cholesterol, blood pressure, presence of diabetes, so it's a yes or no thing, and then it'll spit out a number for a 10-year risk and a lifetime risk. And age is a big driver of the calculator, and you can actually, now there's an app now through the AHA website. You can go to, there's one for Android as well as on iTunes. It's free. You can download it and play with it if you haven't already done that. And you find, and if you put your own numbers in, you'll find that age is the big driver for this calculator. And it also underestimates or overestimates risk. It underestimates risk. It doesn't, essentially you can't use it in other ethnic groups beyond Caucasians and African Americans. It can overestimate risk when you use parameters in Asian patients. It can underestimate risk in Native Americans as well as South Asians. So there's that part. The other important thing, I think, is that family history is a big thing for management of lipid disorders, and there is no mention of getting a family history and utilizing it in your clinical management, and I think that's a big drawback. And everywhere along the guidelines, which are actually quite well written and are 57 pages of text and then plus 30 of references, they say they use this term, use clinical judgment as needed, at least 3 or 4 times. But this guidance is not really well outlined. What does that mean in the community? How are you going to use that? So that's a little bit of a negative, I think. But these guidelines actually give us an opportunity to provide individualized care, patient-centered approach. Personalized medicine is all what it's about these days. So they do offer that. And also to keep in mind, these guidelines are not law, they're not rules, they're just guidelines. There are a bunch of people sitting near an airport hotel conference room. That's how they come up with these guidelines. So, and one important thing I forgot to mention is how they came up with this is they only looked at 27 randomized control trials. They did not use observational studies. They did not use epidemiological studies. If we didn't have epidemiological and observational studies, there wouldn't be, evidence-based medicine. But they used the gold standard in research, which is the RCT, and that's how they came up with these guidelines. So, what about HIV in patients? So again, to summarize, it's a big shift, no goals for LDL, and then using the risk calculator in these new guidelines. But these risk scores have not been validated in HIV individuals as of yet. More and more, there's been one study in non-HIV patients, but nothing yet that has been validated in HIV-infected individuals. So let's move on to the cardiovascular risk in HIV-positive individuals. So I like to think of HIV as a cardiovascular risk in itself. So the reason for that is because patients, even untreated HIV in infected individuals, have an atherogenic lipid profile. And what does that mean? An atherogenic lipid profile is essentially this. This is very similar to somebody who has type 2 diabetes. High triglycerides, low HDL, normal LDL, whatever that might be. And when you have that profile, the LDL particles are very small and dense. And what that means is they're small and they can get into the nooks and crannies of the artery wall. In HIV, when there's HIV viremia and untreated with medications, the cholesterol level itself is low. And so they have a low HDL, but the triglycerides go up, and that's probably because of cytokines and other inflammation, which can increase free fatty acids, et cetera. But this is a typical lipid profile in somebody with HIV infection. In patients who have HIV-related lipodystrophy due to drug therapies, they also have increased dyslipidemia incidence, and it's also associated with insulin resistance, all risk factors for cardiovascular disease. In addition, HIV individuals also, positive individuals also have increased cardiovascular risk. Many of them tend to be smokers. They also have hypertension, insulin resistance, all cardiovascular risks. And something I did find was that in some individuals there may be associated cocaine use, and this also increases the cardiovascular risk in this population. So what are the special considerations in management of lipids in the HIV positive individual? So there's 3 different points. There's ART, effects of ART on lipids, and then there's drug interactions, and there's pre-existing dyslipidemia before even ARTs started. So what about ART drugs on lipids? And these are things you are familiar with, so I'm going to just breeze through these. Protease inhibitors in general are bad. You can't really generalize it as a class effect, but the really bad ones are lopinavir, ritonavir combinations, and there's also associated myocardial infarction risk. The NRTIs, the bad one is the first one there, stavudine, with significant metabolic abnormalities. The earlier ones not used as much, I would think, but the other NRTIs have fewer lipid effects. And the lipid neutral ones are the NNRTIs and the integrase and CCR5 antagonists. What about statin use in patients with HIV, on HIV therapy? The key points from this table are that, just don't use lovastatin and simvastatin, particularly if they're on protease inhibitors, simply because there's interaction with the cytochrome P450, 3 or 4 isoform, and lovastatin and simvastatin levels are significantly increased, so it's just not worth the risk. Other drugs, atorva, prava, rosuva, and pitavastatin can be used. Atorva, with close monitoring and lower doses, I'm okay with using, and I know you guys use it in a similar way. Prava and rosuva, these days I think rosuvastatin is more potent, so probably a better lipid-lowering drug. And pitavastatin doesn't seem to affect the, there's no change in the AUC, so, and it's also, there's actually a really fresh off the press study with pitavastatin and one of the NNRTIs, efavirenz, I think, and there's no interaction, so it's a good drug to use. So what about pre-existing dyslipidemia? We'll briefly go through this. On the left, you have the individuals with very high LDL levels. That means it's genetic and it's not related to the drug. And so those are individuals who have familial hypercholesterolemia and so need aggressive lipid lowering because it's a premature cardiovascular disease risk. The other dyslipidemia you could come across are the mixed hyperlipidemia, where you have mixed pattern, which is high triglycerides as well as cholesterol, and it's a high risk for myocardial infarction. And the way you diagnose this is with family history. Many individuals in the family with the premature cardiovascular disease. But in general, general lipid management guidelines still apply. So lifestyle modification is key in these individuals, and other risk factors like hypertension, very important, smoking cessation, and diabetes.